Well, good afternoon, everybody. Welcome to this this session. This is one of a line of lectures, I think, called Monday Lunch Live, something like that. For the lunch you've had, and the live part starts now. I'm Bob Thomas. I'm the Vice Chair or the Deputy Chair of the VCCC. I'm sure most of you here are quite at home where you are, but you are in the VCCC building. The building is a mere nothing, spectacular as it is, but it confers upon the 10 partners a demand for collaboration and effective work to make things better for cancer patients, both research and clinical care. And that's what it's about. Adds value to all its partners. So welcome to the VCCC. I should also recognise the original owners of the land, even though we're how many floors up here on which we stand today. The Wirinju people of the Kulin Nation, and respect their elders past and present. I'm absolutely delighted to chair this meeting, and I must point out that I'm standing in for Professor Grant MacArthur, who's unfortunately and unavoidably been called away to another place, but he personally asked me to look after our speaker, whom we all know very, very well. So, Professor Sanchia Aranda, I won't go fully back into the past details, but we do go back quite a long way. I'll simply say that Sanchia has connections with most of the institutions around the VCCC, and in recent times has had very powerful connections, being a Professor of Nursing Research at Peter Mac, and she still has a link with Peter Mac and the University of Melbourne in the nursing research area, I believe. Is that right, Sanchia? More than that, she is the president of the UICC, the Union International Cancer Control, based in Geneva. We will hear something about that today, I'm sure. She has been president of the International Cancer Nurses Society, and I think she's been president of COSA too. No! Oh, one thing she hasn't been. So I'm sort of not making this up as I go, but I'm sort of putting it together as I assume. But Sanchia is, of course, a nursing background originally, but has expanded into many different areas. And I've forgotten one thing she was, which was Deputy Director of the New South Wales Cancer Institute, and she performed enormously competently in that role and set them on the way to becoming a major data-driven organisation. So, Sanchia, welcome very much. Now, I have here that Sanchia's going to talk about it. It's a fascinating title, and I would have come just for the title. It's called City Cancer Challenges, is what I've got. There's another title up here which is even more complex, but you'll undoubtedly tell us what about. And the sort of broader title is City Leadership, the Answer to Global Cancer Control. So, Sanchia, welcome.
Thanks, Bob. And yes, the City Cancer Challenge is an exciting new part of the UICC, or the Union for International Cancer Control's agenda, and I'm here to talk to you about that today. This challenge actually stems from a growing frustration with national cancer control plans, which have been the agenda on the global landscape for a long time, where the idea was to get countries invested in planning for their cancer needs and to then implement those. But unfortunately, national cancer control plans have had a bit of a checkered history, and many of them sit gathering dust on shelves in government offices. And so this really came out of some broader thinking around how to move that forward. It's important too, in Bob providing the introduction and welcome to country, I also would like to pay my respects to the traditional owners of the land on which we meet today, and pay my respects to elders past and present. And I think that in thinking about the Indigenous population of Australia, we think about the people who've got the poorest cancer outcomes in our world. And I think that provides us with a really interesting global perspective on cancer outcomes more broadly, and that's the journey that I want to take us on today. But just firstly, a little bit about UICC. It's an organisation that is the oldest and largest cancer fighting organisation globally. It was established in 1933. It's had a very checkered history of, and particularly in recent times, but about 8 years ago, UICC took the bold step of moving away from being an organisation largely run by a governance or a committee, an international committee of health professionals, to appointing a CEO. And the CEO happens to be a banker. He'd come out of the global financial crisis looking for something that was of worth to do, and he became the CEO of our organisation. And I think one of the things that journey is from 389 members to over 1,000 members in a very short space of time gives us I guess, traction internationally to really begin to change the conversation about cancer. We are also an organisation that has, as well as being a membership organisation, so we're not individual members, though those 1,000 members are organisations made up of people working in cancer, so professional organisations, hospitals, like Peter Mac is a member, universities. We also are, as a civil society organisation, in official relationships with the United Nations and with a number of other UN agencies, particularly the World Health Organization and the International Agency of Research on Cancer, but also the Atomic Energy Organization, Drugs and Crime, and also around some things around social aspects of health delivery. And we have a whole range of partners who help us really with our agenda. And I think over the last 5 years anyway, really trying to place cancer in a broader conversation in the international landscape around non-communicable diseases. So we're a founding partner of the NCD Alliance. UICC does three main things. We convene, so we bring people together in conferences and summits and seminars around the world. We try and build capacity, so we invest in fellowships and individuals. We foster peer-to-peer capacity building. But our biggest agenda has really been around advocacy. And in particular, our advocacy agenda is around creating better equity in global cancer outcomes. And to do that is to really integrate cancer control within a global health and development agenda. And as I said before, we've spent a lot of time in the last decade focusing on national cancer control plans, things like cancer registry development, and we've had a few wins within WHO in terms of resolutions on palliative care, resolutions around essential medicines, and the essential medicine lists that WHO developed. The cancer one had a major expansion in 2015, largely as the result of UICC's work, and in particular the work of EVIQ through Cancer Institute New South Wales, where a lot of the rationale for the medicines being available came out of that initiative, and also essential technologies. And we've also been part of some really important work on global access to radiotherapy and global access to surgery. And so trying to have the advocacy toolbox. And we started a conversation around how do you advocate for investment within more local environments, which is where the initiative I'm going to talk today came from. But taking a step back, let's have a look at the global cancer burden. So this is the sort of rising rate. The big circle is the incidence of cancer rising from 2008 at just over 12.5 million cases of cancer internationally to 19.5 by 2025. And 2025 feels really close and around the corner. And the rising death rate from 7,500 people dying from cancer globally to 11.5 million. And remembering that in low and middle income countries, around the middle of these circles, cancer overtook malaria, HIV and tuberculosis combined as a cause of death in low and middle income countries. And yet we were in the world of the Millennium Development Goals, which only paid attention to communicable diseases and paid no attention at all to cancer and other chronic diseases. But so if you look at this projected incidence by region of the world, from developed to more less developed, you'll see that a massive amount of the increase in incidence is actually occurring in the countries that have the least resources to deal with that. And so it's almost double the increase. But if you look at it from the perspective of cancer deaths, we currently see about 65% of all cancer deaths globally occurring in low and middle income countries. And over the next decade, that's going to rise to 77% of the deaths from cancer will occur in low and middle income countries. So this disproportionate burden in countries that already face a disproportionate burden of communicable diseases as well. From a global distribution perspective, I talk a bit with my colleagues at Cancer Council around what our obligations are to our region. And if you think about the global distribution of cancer and you think about us sitting, I think, increasingly positioning ourselves as part of Asia, almost 50% of the incidence of cancer in the world is currently occurring in our region. We have the rapidest growing economies within our region, but it's over 50% of the deaths are occurring in our region. And so if we think about where Australia and where the VCCC positions itself, this is a really important region to be a part of. It's also the part of the world with some of the fastest growing urbanisation, which also links back to what I'm going to talk about. So when we started these conversations around the time of the high-level meeting on non-communicable diseases in New York, where the global NCD targets were set, part of that agenda was how do we actually set these targets in a World Health Organisation, so the World Health Organisation set the targets, that had nearly all of its work focused on Millennium Development Goals. And so this is the development over the last couple of years of the Sustainable Development Goals has been really important because it's widened the frame of reference. And if you think that that's just words on a page, what the Millennial Development Goals meant was global investment in communicable diseases and in the billions. So places like the World Economic Forum invest in the development of communicable disease services. But less than 1% of the global development investment went to non-communicable diseases. So the shift to the Sustainable Development Goals is a really critical step in trying to mobilise investment around cancer and other NCDs. So the City Cancer Challenge is came out of a conversation that Kerry and Julie, our advocacy officer, and myself had about how do you begin an advocacy agenda to get cities to take responsibility for their the health of their population, and is it a way of actually mobilising an investment that transcends some of the interesting things that happen within governments when you're trying to make investment decisions. I was just talking to Chris before about the fact that governments often get really anxious when they start looking at the cancer problem because it can cost an enormous amount. We've got India at the moment thinking that it can't continue with HPV vaccination because it's such a looks like a massive bill for their community. And so this initiative centres around goals 3, 7 and 11 from the Sustainable Development Goals and provides a really interesting framework. Where it comes from us is that we want to be able to convert political agreements, that is the agreements around the NCD targets, into actions. And those actions are we want to increase the number of people in the world with access to quality cancer treatment. We want to address inequities in access to cancer medicines and technologies and to reduce avoidable deaths, particularly in low and middle income countries. The idea of the challenge is that it's a truly multi-sectorial initiative with all city stakeholders being engaged in the design, planning and implementation of cancer treatment solutions. And the cities are at the heart of taking the lead on and being encouraged and supported to run this initiative themselves. We started off, there are about 500 cities in the world with 1 million people, and that was our start list, and narrowed that down, and I'll talk a little bit more about that in a minute. So the reason that we've chosen cities as this initiative is that already 54% of the world's population live in urban environments, and many more have to travel to urban environments for their treatment. But by 2050, there's going to be 2/3 of the global population will live in cities. and that 90% of this urban growth is actually occurring in low and middle income countries. So we're seeing massive amounts of city investment now that we should be able to capitalise on in terms of the development of city-based health initiatives. And it links as an initiative with a whole lot of things, including the World Health Organization and UN's own reports on urban health and the need to really look at using urban hubs as part of the way in which we invest. So we're targeting, as I said, all cities over 1 million people, and that really inviting them to think about joining this challenge. And some of those challenged cities will be supported, and I'll talk a little bit more about that in a minute. But ideally, every city will invest in having a comprehensive set of cancer services available to its population. But we're looking for 5 to 10 cities in low and middle income environments that will be key learning sites for implementation during 2017 and 19 as the first cycle of this work. The cities are, as I said, population of greater than 1 million, and to become part of our the learning cities, that special 5 to 10, they will get full support. So we'll put in-country resources in. We'll also have regional coordinators. And we've selected the cities based on a set of fairly rigorous criteria. There's about 40 criteria in descending order. So things like stable government and safety are part of that criteria. They need to have some basic services already available. You're not going to start building cancer surgery if you don't already have surgery. If you've got to build an operating theatre, it's probably a bit over the top to think that cancer is the main priority. But there's also can be challenge cities. So Melbourne could join as a city, or probably 3 cities at least, to join the challenge and pull in on the principles. But our focus at the moment is on these learning cities. The first 3 that have been selected are Asuncion in Paraguay, Cali in Colombia, and Yangon in Myanmar. And we're currently looking for another Asian city, and we're about to announce an African city. And each of these cities are different. But there's been an intensive process of engaging these cities for the challenge. So there was an expression of interest sent to 40 of the target cities. Nearly all of those cities responded positively, but we got to about 16 that met the criteria, and 4 out of the first 5 that were approached came on board. There's been some interesting challenges. You can't do this challenge in Indonesia because you can't mobilise overseas trained doctors into Indonesia. You can't register as a medical practitioner in Indonesia if you're trained outside of Indonesia. So there you find all these interesting things about how cities and how countries work that become challenges to development. So each of these cities is joined for very different reasons, but you can see reflected on this side some of the things that led to decisions about particular cities. So in Cali, there's a track record of improving cancer survival rates. They've been running a registry, they've been systematically beginning to improve the way they deliver services, and the challenge is about giving them a boost up in terms of improving that. In Yangon, their government has actually put cancer as one of its top priorities. There's really strong UICC membership, so in all of these initiatives there's a strong civil society leader in place. That was one of the criteria. And in Asuncion we know that again there's this really strong civil society support. So you can get a bit of a sense of the sorts of things that Sue Henshaw and her team who are leading this have undertaken as they've gone out to engage. And so what these cities are agreeing to when they join the challenge is that they commit to being able to work with both public and private sector. These initiatives are not going to get off the ground without private sector investment, and so there has to be the capability of bringing those things together on the ground. They have to be prepared to be open and transparent and participatory in the way that they make decisions. So these initiatives can't be government top-down approaches into cities. We want city leaders, civil society, the clinicians, the governments all around the table having shared commitment, so that if there's changes in one sector, it doesn't took the initiative over, because that's what often has happened before, is that a government will commit to something and then the government changes and the whole thing falls over again. So a much broader cross-partisan approach. And they're also committing to work with the global and regional teams to take the learnings forward for other cities as they join the challenge, and they have to commit to measurement. So the first piece of work that is done is an entry point or a baseline, measuring an establishment of what exists already. This is against a baseline from a document called the City Cancer Challenge document on the left, which is the technical support document. That work's been led by a surgeon, Anil De Cruz from Mumbai in India, but with a multi-sectorial group of clinicians who've really begin to define what needs to be in place for the beginning of cancer treatment. And this baseline measure creates the baseline from which each city's development agenda can be set. So the planning is based on what's in place at this beginning point. And what that means is that there's not a one-size-fits-all approach to this. Each of these cities will be quite different in the way that the challenge is taken up. And so the needs assessment that will be undertaken will cover off on these 4 areas. So obviously you've got to have core cancer services in place, but you also have to have management. You've got to have governance of those services and the ability to implement. You need to pay some attention to quality, and I'll come back to that towards the end, because I think that talking about evidence-based protocols is easier said than done, and lots of those things are really fundamental to get right in the beginning. And then looking at factors around community access and integrated care. One of the biggest challenges in low and middle income countries is the extent of disease that people have when they first present. So if you don't focus this around things like optimal care pathways and engagement with community for people to get to the cancer centre, then you will automatically lose. And so we're focusing the inputs on things like the facility or the space that's available for cancer centres. This is not necessarily about building buildings, but in some of these organisations or cities there will need to be investment in infrastructure and facilities, looking at investment in equipment, but critically also investment in the health workforce. And some of the biggest challenges, not only in the cancer treatment workforce, but also in things like diagnostics, and paying very early attention to how much of that you can actually support remotely. So investment in things like telepathology, for example, are all things that are partners that are being considered. And so the cities will get supported, as I mentioned, in developing a strategic implementation plan, and then what UICC's role is to start to link them with technical advice and investment partners that will help them to deliver those plans on the ground. And we're creating a global network of experts who can help to do that. And in fact, we've already started to have a conversation with COSA, the Clinical Oncology Society here in Australia, about how we can begin to bring the people together in Australia who are interested in providing technical support within the region, and how do you mobilise organisations like the expertise in the VCCC towards that kind of support. The other major part of this, of course, is the financing solutions. There's a lot of money being poured into the initiative already, but that's really providing the on-the-ground support. What we've done is begun to look at partnerships with whole of industry. So we've got a partnership, for example, with the radiotherapy equipment providers as an industry, not as individuals, but to come to the table and be part of this initiative. They've come together as an industry. The pharmaceutical industries come together as an industry. And this has been really important from a whole range of perspectives. One is you get the commitment, but two is from a UICC perspective, our relationships with WHO are very tenuous in terms of they don't like you really playing with the private sector. So doing that in a way that doesn't threaten those relationships is really important. So one of the things that we commissioned was a financing sustainability report from the Dahlberg Group. And so this outlines the kinds of approaches that cities around the world have already used for these kinds of initiatives. And these two reports became very instrumental in February of this year, where we launched this initiative at Davos with the World Economic Forum, and they've elevated this project to be a level 2 project within their structure. So, by way of illustration, the massive investment in HIV/AIDS occurred when they were taken on as a level 2 project within Davos. And that led to billions of dollars worth of investment in low-cost solutions for HIV. So being accepted as a level 2 project is really important. And the challenge that the Economic Forum are now looking at trying to achieve is to develop a $1 billion investment fund for low-cost loans to low and middle-income countries for infrastructure investment. So a really important next step in taking this from what started as a little advocacy idea to something that's growing faster than any of us can imagine. This has all occurred across just over a year of time, and every now and again Kerry and I look at each other and get a bit scared, because it is going to be bigger than UICC as an organisation. So what happens within each city is that we're helping to create a city executive, and they take the lead, supported out of our team within UICC in Geneva and also the regional office. And then we put a manager in place in each city who does all the coordination and linking. We bring all of the ministries of health and the stakeholders together, and then we start to align the implementation partners. And then that will occur over 12 months. We will get to a point of saying, well, is the city ready for a major investment as part of this initiative? So where we're at the moment is we've developed the city tools for financing and gap assessment. We're beginning to define the framework for measuring impact. And you can imagine that that's going to have some things that are common across all of those cities, but other things that will need to be quite unique depending on the nature of the city. We've done the needs assessment in the first of the key learning cities. They're in that process. We've brought them all together in February, the 3 cities that have been selected, so that they can start to learn from each other. And we're continuing to have conversations with cities who want to join the challenge versus the learning aspects of this work. In 2018, we're going to spin this off as a separate NGO because, as I mentioned, it's going to be bigger than UICC. It's starting to swamp us already. We've had to move offices to just accommodate the extra staff, but also we feel that because of this interesting public-private relationship, that it's better that it sits with its own governance. And it's going to be a thing called the Healthy City Partnership, not the City Cancer Challenge, because we think that the next challenge after the City Cancer Challenge is one around prevention and being able to think about that in a broader NCD environment, and to really think about how cities for health becomes part of a wider strategy. As I mentioned, it is multi-sectorial. Cancer societies, networks as alliances, these are all the partners that are already on board. I think you'll see there that we've got builders of cancer services, so groups like ICON here in Australia and the University of Pittsburgh Medical Centre are not-for-profit organisations that actually provide private services in many countries, and those are the sorts of organisations that come on board but also create a whole other set of challenges, and I'll talk about that in a second. But lots of different organisations coming together, and every time you talk about this initiative with another organisation, they all want to be part of it, and finding ways to manage that is creating its own challenge. So I think this creates a few big ticket questions. So this is my list. This is not the official. I'm talking as Sanchia Aranda now, not president of UICC. I think the delivery of technical support is going to be a very big challenge. The current model in low and middle income countries at the moment is that you'll have somebody sitting somewhere in a hospital or a university who thinks, I want to do some work in Africa, and then they go and they pop down and they do stuff, and then when they run out of money they leave. And in any particular city there'll be 10 or 15 of those people there doing that. And so how do you bring all that together and have it mobilised around a single solution, actually driven by the city, not driven by the technical people who come in and have their own particular thing that they'd like to achieve. So self-determination and local control over these initiatives is going to be in tension with what the interests of technical providers are. And those of us who are used to providing technical services in high-income countries have to rethink our lens very carefully when you then plop yourself down to provide that technical support in a lower middle income country, and keeping those tensions in healthy balance will be important. I think controlling private sector interests and having quality over profit is going to be a really important challenge. You know, organisations like ICON do a great job, but they are in the process of building 15 cancer centres across China at the moment. And so what is driving that, and how much of that is driven by the local needs versus the organisation's growth needs. And I shouldn't pick on them as an individual, but I think it's a really interesting example where we're seeing lots of tension about that in the Australian context, and we don't want to set up in low and middle income countries high levels of dependence on private sector investment. I think it's also one of the things that we're going to have a big conversation about in May in Geneva is around defining low-cost solutions. We've just gone through our own NBS review process here in Australia. The radiation field is changing massively, just using as an example. We've still got an approach that is going to foster pay by fraction in the same context that we're seeing something like breast cancer and prostate cancer treatment being able to done in 3 weeks versus 6 weeks. But if you've still got a system where 6 weeks pays more, what's going to happen in a private-public partnership environment? And so we think that there's going to have to be some defining of the solutions that will be funded in these environments as opposed to the ones that won't, so that you can actually drive, remembering that this is, if you do 6 weeks of treatment in a low-income environment for one patient, it's another patient that misses out. If you can do 2 patients for that same delivery of resource, then you actually start to change equity issues. And so it's going to be the same issue over things like access to medical oncology drugs. You're going to choose the ones that, even if you've got an investor, that provide you with 3 months of life, or are you going to put that investment into a screening program for early detection where you can cure with maybe surgery and radiotherapy alone. So really, I think, interesting tensions that will happen. And they then speak to sustainability. If you build a facility but you haven't got a sustainable funding mechanism to keep that going through whatever it is that you're developing with private sector or with government, issues around, is it only going to be for the haves, the people within these environments that do have health insurance? What is the needing to happen with government policies around universal access to health system? And then you have to think about the broader health system integration. If you're going to build surgical capacity, you don't want that to just be for cancer. You actually need to think about the health needs of that community and work in an integrated way. You need to be able to integrate, as I said, with the primary care sector so that you're making sure that patients actually come early rather than late. And you have to be able to evaluate outcomes, and you're not going to be able to achieve this if you don't have great registry development and be able to measure cancer. And can we do some things on the ground in terms of much better clinical data systems, because most of these facilities will be built around radiotherapy availability, which has already got great information systems. Can we tack on to that so we've got better ability to measure outcomes? So some big questions that you might like to explore with me. If you've got some answers, then that would be good as well. So as Kerry Adams says, who's our CEO, is that it is the first of its kind initiative galvanising multi-sectorial partners to address cancer treatment and care. A lot of people have been while enthusiastic, somewhat critical that this is not about prevention and it's not about screening. But we've taken this advice really carefully, in that many of these low-income countries, most people diagnosed with cancer are diagnosed with advanced disease. And you have to start creating the possibility of survival to change the mindset. You actually, it's as much about changing the attitude or the stigma associated with cancer as it is about the provision of services. And that these things, you can't ethically begin to do something like screening and early detection if you can't back that up with a good quality treatment environment. And so this is a call on governments and NGOs and UN agencies and all of the domestic and international businesses that can come together and actually make some solid advances in making cancer less of a global inequity problem. That's the talk.